If you're a driven, active person who wants to reach and pursue a higher quality life with some ambition, then guess what? This podcast is for you. This is the Driven Athlete Podcast. What's up, y'all? It's your man, Dr. Kyle, Driven Athlete Podcast. Welcome back. We got Dr. James Ghattas with us again. Thanks for coming in. I know you're a busy dude, so appreciate it.
It's good to be back.
Especially, thank you. And especially with some interesting interactions that happened today before you got here.
We'll leave those off the record.
Yeah, it's awesome. So I appreciate you coming in. Remind everybody again where you're at, your practice name, what y'all do, and what you're focused on.
Definitely. So Dr. James Ghattas, I run Palm Beach Regenerative Sports and Spine. It's a regenerative orthopedics practice. I'm a licensed Regenics physician, so I offer Regenics orthobiologic treatments. We're right here off Palm Beach Lakes Boulevard and Village, right in the Renegades Plaza. And we've been, seeing and treating patients for orthopedic and musculoskeletal issues for 2.5 months now. So we're on a roll.
Yeah, that's awesome. And then, getting busier, I assume.
Definitely getting busier. Thank God.
Cool. That's awesome. And helping people, that's the main thing. Clarify everybody, orthobiologics, what that means. Stem cells, right?
Yeah. So orthobiologics is basically using your own tissues to treat any sort of musculoskeletal problem. So PRP, plasma, super concentrated platelets, mesenchymal stem cells, which comes from your bone marrow, and then a host of other things like prolotherapy and adipose and hyaluronic acid, things like that. Yeah.
Cool. Yeah. Prolotherapy. I've had several providers, clarify. Definitely recommend that and think it's a good option. We'll explain more of that.
Yeah, I love prolotherapy. Prolotherapy because of its simplicity and how effective it is. So it's literally dextrose, 12.5% dextrose. You can mix it with some ropivacaine to make things more comfortable for the patient. And it's injected into, a variety of tissues like tendons and ligaments in order to do two things. One, it kind of acts as an osmotic gradient to sort of tighten up ligaments and tighten up tendons that are sort of lax or loose and have some instability.
Okay.
And it is a mild irritant to the tissues. So it triggers a mild inflammatory response to kind of kickstart that healing cascade again.
Right. Okay. Prolotherapy, it creates a mild irritant and purposefully to create an inflammatory response, right, and a cascade of purposeful regenerative process, right?
Yeah, exactly. So the whole premise is that, we heal and regenerate from injury because we have blood supply. So like when you cut your skin, the first thing that shows up obviously is bright red blood, and then the blood kind of slows down and platelets start to aggregate, and then the blood stops, and then you get a scab, and then however many weeks later, you're left with either a scar or a minimal scar or something like that. So blood kind of carries all of our healing cascade. Our musculoskeletal tissue, specifically ligaments and tendons, just inherently don't have that good of a blood supply, and cartilage too, I forgot to mention. And so what happens is the degeneration, the rate of degeneration sometimes outpaces our ability to heal. And so we need to encourage blood flow to go into that area. So by injecting prolotherapy or this dextrose solution, you're kind of essentially injuring the tissue, very mild injury. And so it redirects blood there, kind of cues the body to say, hey, there's an injury here. Let's divert some nutrients, divert some blood and so on to that area. So It's logistically super simple because you don't have to take blood and process and do this and that. It's readily available. So it's a great tool to have for most practitioners.
It makes total sense. And also it sounds like a lot of the dry needling, right? The effects that we try to pursue with purposely stimulating a healing response, a little bit of micro trauma, right?
Yeah, exactly.
Musculotendinous junction or at the tendon or the insertion site for something like a long-standing rotator cuff type pain or tennis elbow pain or whatever, for a tissue that's degenerative at this point, like a tendinosis versus like it's acutely inflammatory response. But to stimulate a purposeful healing response and blood flow, mild micro trauma, and then the cascade of healing, and it beelines all the blood flow and all the healing factors that would accommodate with that.
Yeah, exactly.
What have you? I'm sure you've. With dry needling, we do it very often. With that, with prolotherapy, in addition to dry needling, would that be too aggressive, or do you think it's a good follow-up treatment?
No, actually, I think that's a great idea. When I was out in Colorado, we would frequently have our, patients who are getting treated with either Prolo or SCP be immediately evaluated and seen by our therapist that we had in-house then. And he was very talented at dry needling. He actually trained a lot of the other PTs in the Denver area on dry needling. So we would use them hand in hand. And it basically, the 30,000 foot view is that it just keeps you in that state of healing response, as opposed to it sort of, dying down and kind of entering into that sort of chronic phase again.
Right. You mentioned cartilage, right? Which from our understanding is, basically aneural and avascular.
Yeah.
And some interesting research that I've come across and was presented with, and I was like, this makes total sense, of like, maybe this is the cure for arthritic changes, degenerative arthritis, which is like progressive and you can't reverse it. But some research, I'm going to get your opinion on this. But what I've been exposed to and seen, and I'm like, this makes total sense. And hopefulness, right? Totally. And like a thought of like, how do we approach this then? Of repetitive, intermittent compression of the joints, which is exercise. Right.
Oh, yeah.
Purposeful.
That's exactly what that is.
Purposeful compression. It's just a matter of like not being too aggressive. What they're finding in some of the research is like pre and post MRI imaging is for arthritic cartilage joints. They take an image 8 months prior, 12 months. This is like a 12-month, 24 months time. With purposeful, non-aggressive, non-inflammatory exercise, where like your symptoms would tell you, right, this is too much, right? Yeah. So it's like, I feel good, I feel loose, I feel warmer. I actually feel better now than I did 20 minutes ago after doing, or an hour ago versus for doing some exercise, some movement stuff. Okay, cool. If we keep it at that level for 12 months, post MRI was showing more vibrant, brilliant, and thicker cartilage. Oh. Whereas a control group that wasn't any exercise was still thinner and more brittle.
Yeah.
And I was like, how is that possible though? If it's avascular and neural, I'm like, well, maybe it's just growing from the subchondral bone and growing vertically from there. Like if you imagine like from underneath, and it's feeling the compression from the subchondral bone, and it's stimulating an adaptation underneath that and growing cartilage from the ground up. That's what I was surmising, right? Like that not really explaining. Maybe it's just a response. And then also the argument of like the synovium and the synovial fluid for the nutrients to stimulate more of that and then imbibe through the cartilage. I wonder, what are your thoughts on that?
Yeah, I mean, it's almost like poetic, right? If you kind of step away from the deep technical science and you just sort of look at like what these cells are. A cell is basically this, factory. It's got a purpose, it's got a function, and its function begets its structure, or vice versa. Sorry, its structure sort of begets its function. Meaning that the way it's built kind of determines what it does. And it's sort of, it doesn't have like a consciousness. It doesn't know that like, oh, I'm a cartilage cell and I know how to make. It basically relies on its environment to tell it what to do.
Yeah.
It relies on its immediate environment to tell it what to do. And so if you are a cell that is primarily responsible for taking blood from the matrix of bone and then putting out cartilage on the other side at that sort of like bone cartilage interface, then you need the stimulus to tell you that, oh, it's cartilage making time.
It's time, yeah.
And the time to make cartilage is when there's impact and friction and movement and, dynamic forces and so on. So it's just, and then you can kind of apply that principle to almost any cell type.
Yeah. There's a study that I came across that I was like, this is mind blowing. It was like, I think it was in the running or in the conversation, like a Nobel Prize almost, but it was a study of a group of beagles, dogs, and a control group, and then a group of experimental beagles, and they tested their knee cartilage. They did an image ahead of time, and then it was an 11-year study.
Oh, wow.
11
That's
years.
Like the whole lifespan of the dog.
Yeah, exactly. And they had them wear a double weighted vest of their body weight, a double body weight vest. And they ran 7 miles, 5 days a week for 11 years.
Yeah.
Versus the control group that just played normal dog stuff. And at the end of this is where it gets controversial. They sacrifice the dogs and they open their knees up to investigate their cartilage. And the experimental group that ran so much, their cartilage was thicker, more vibrant.
Yeah.
And more resilient and like looked healthier. Yeah. Whereas the control group was more brittle and thin. And so anyway, suggesting what's like, well, maybe exercise, running in this particular, with dogs as an example, but just the compression that comes with exercise, resistance training or running might actually be beneficial and not detrimental for degenerative changes.
Yeah, I mean, it's like we're finally sort of coming to this understanding that, as a soft, squishy, fleshy organism, we adapt to our stimulus.
Yeah.
And so if you are, if your body's put under this demand where you need to exercise and do certain activities, like it will adapt, barring any other like genetic disorder or something like that, or some, maybe some mechanical issue that is causing a repetitive injury or something.
Exactly.
Like
I feel like, yeah, but that being said, like, it's just a matter of trying to limit the compensation patterns as much as possible, and disparities in like strength, stability, and joint range of motion, where some things are going to take more brunt of the impact and other things are going to take less brunt. So you would imagine the ones that take more brunt are going to get broken down faster.
Yeah.
If you can't disperse the forces distributed equally, or just too much.
Yeah.
Like just overload, right? You're just training. It's just too aggressive and too much past the point of like a benefit, and now we're just detrimental, like that makes total sense.
That actually, like that interface that you're kind of describing right there is sort of the sweet spot for me, because, most often if you get somebody who's got some sort of, kinetic chain dysfunction or a movement disorder essentially, and you get them in with good therapy and they respond to it, great. But if their tissue is like already sort of exhausted, there's like a threshold beyond which the tissue just can't keep up with the demand that it's being put under. And so that's where doing biologic injections tends to make the most difference, at least.
To facilitate what you want.
Yeah, it's like, okay, I'm going to give that tissue the tools it needs to sort of respond to the stimulus that we're giving.
Yeah.
Yeah.
In what situation would people find themselves where that would be a huge benefit? Like what's the profile? What's the time? What's their symptoms and stuff?
Yeah, I mean, so a common example I see is people with neck pain or cervicalgia. And that is usually because at some point in their life, they sort of lost that posterior curvature of the neck. They lost that cervical lordosis. And we're going to start seeing that a lot more in the coming years because of our
technology,
our text culture, I mean, I have it. My neck is straight as a board. But basically, you sort of see that clue that they're going to start having micro instability and degeneration and things like this. And if they don't respond to PT in the sense that they leave therapy every time and just feeling like they're not getting any better, or there's so much pain to where they're kind of reflexively inhibiting muscles, then you should know by like a few weeks if that's like, okay, if continued therapy is gonna help or not, or do they need a boost, basically?
Intervene,
Yeah. So the way I see that in clinic is, I'll see somebody for an initial problem. If they're, in therapy or not yet in therapy, I'll get them in and we'll do a follow-up. I'll use that time to get imaging, which takes a few weeks in some cases. And then also follow up with them and see how they're doing with their therapy. And if they're like, I mean, there's an asterisk by this, but if they're really, trying their best and they're actually getting good quality therapy and they're still not improving, then I know like, okay, we definitely need to treat.
Intervene somewhere. Yeah, totally.
Yeah.
It's interesting is like for the right candidate, or if someone's like, it's not getting better and it's been going on for a long time. I've said some mentors, because I used to get frustrated. Be like, why aren't you, we're doing this? I'm like, I'm intervening here. Like you should be getting better. You're doing exercises. And they're like, well, I'm doing some of them. I'm like, okay, well that could be better, of course. But like, wait, this doesn't make sense. I'm getting frustrated. And they're like, well, did you ask them if they want to get better? And I was like, what do you mean? And they're like, well, like ask them other questions. Like, what's your vision look like?
Yeah.
Like, what do you want out of this? Let's say like wave a magic wand in like 6 weeks, you feel totally like you're what you want, the outcome has been presented. Ask those type of questions. Like, what do you want? And like, how are you feeling? What's like the ultimate win for you? Like, what does this look like for you in 6 weeks or a year? Like, what do you really want? And like some of them sometimes would be like, I just waiting for this insurance claim to fall through.
I hate that.
And I'm like, oh snap. Duh. Like not everybody wants to get better. And in addition, even if there's not any insurance involvement of like some kind of financial gain, which totally understandable, like it's just tough, right? And as practitioners like us, we're like, we want to help everybody get them all better.
Yeah.
And then be like, we're winning this. Awesome.
Yeah.
In addition to that, asking them questions about, just getting to know them, like I have, because we since we spend so much time with people, we have really interesting conversations. I have very interesting conversations with people. Conspiracy theory, like it's awesome. I'm like, okay, tell me more. But anyway, it's actually talk about their family and their relationships and stuff, and then they start sharing more information voluntarily, and I'm like, oh, I see, you've been in pain for a long time, and you've been the center of attention for your family and family support for all these doctor's visits and all these appointments.
Yeah, I didn't think about that.
And you were mentioning previously too, like, but your childhood was like kind of traumatic. By no means am I a mental health professional. I'm just going off of what other professionals told me and mentors and stuff. And I'm like, yo, this makes sense. My conversational topics, my expectations for treatment are gonna be a little bit different.
Yeah.
Imagine if this person were to get better and have no more pain, then they don't need any more doctor's visits and they don't need any more attention from their family. So they feel like they're losing their social support and they feel like they're not important anymore. But if they do have chronic pain and they're always an issue and they have all these appointments and they're always continually the center of attention, it's not like they're craving attention. It's more like, who knows? Like I'm not an expert in this stuff. Unhealed trauma from previously that they need, and a lack of support previously that they want more of that.
Yeah.
And if that's removed because their pain gets better, then they ultimately lose.
Yeah, and that's the tricky part about chronic pain, because it like reinforces thought patterns. And that's why it's hard to get out of chronic pain, because you basically have this stimulus, your brain, your conscious brain at least, is trying to process the stimulus, and unless you like sit and meditate on it or, share your experience with someone and whatnot. This is why psychotherapy is so important for chronic pain.
Oh my gosh.
Because if you're not directing like dedicated attention to why you're in pain, mentally and emotionally, then your brain doesn't get the cue to sort of explore other thought patterns when it comes to dealing with the pain. So you just kind of go into.
I'm sure for you guys, like the people that you've seen that's chronic pain a lot.
Yeah, especially not so much in orthobiologics, actually. Interestingly enough, we still have people obviously with chronic pain, but what I've found is that there's a little bit of a selection bias, because by the time someone has found me or found a provider like me, they've done some research, or they're in a community of people who are thinking this way and have told them. So they're already in this mindset of, oh, I don't want to just magically get better. I want to heal, or like I want to repair. I want to fix the problem. And to be in that mindset, you're already kind of on a different mental, I guess, page. But what I wanted to comment earlier when you were mentioning is that sort of that train of thought where it's like, oh, I just want to get this PT out of the way. Like I'm guilty because that sort of culture starts in the doctor's office, because when you're beholden to the insurance model, what ends up happening is that physical therapy becomes an obstacle to your reimbursement.
It's a gateway to like, well, let's just stop messing around and let's just get this thing fixed, or my settlement will come through.
Yeah, and
to
like,
show that it failed. Like, oh, great, you just belittled everything we did.
Yeah, exactly. And like the words we'll say is like, okay, you got to get this physical therapy done so that we can do the injection. And so in their mind, they're like, all right, well, let me just get this out of the way as fast as I can. Yeah. And so it's also that,
it makes sense.
That mindset starts there, unfortunately. And that's again part of the reason why I left traditional sort of insurance-based pain management, because I know that in reality, my treatments aren't as effective on their own, and they're way more effective if the person is getting good therapy at the same time. And when I say therapy very broadly, I mean that could be good chiropractic care, that could be shockwave, that could be dry needling, it could be just exercise, that could be meditation, honestly. So there's, it's all out there.
Yeah, I think the chronic pain thing, like it's just a topic that I'm super interested in. It just makes a lot of sense. Yeah. Where and just the thought of, like you were saying, like to quote a mentor's initial quote to bring this topic up to some of our lectures and stuff. He's like, to quote Lil Wayne, pain is an opinion. Yeah. And I was like, what? Like, okay, cool. You're so hard, or you're so tough. But ultimately he's like, pain is an output. Mm-hmm. It's not an input. Like your arm doesn't tell you it hurts. It just sends signals that are assimilated and digested decided, and then a decision's made. Yep, that hurts. Yeah. Because it's inanimate, right? The only thing that's actually conscious and aware is our brains, right? Yeah. Like nothing else is actually aware and inanimate, so alive. So like knee pain, neck pain, back pain, referred pain, sciatica, like everything. They're just input signals.
Yeah. The actual, like the definition of pain, if you look up, I can't remember, it's like the International Society of Stuff That Hurts, something like that. The actual like formal definition of pain is the perception of injury. It's not actual injury.
Yeah.
So that right there, just in that word perception, it just holds all that detail.
Yeah, I love that. I'm sure with your neuro stuff, did you guys dive into that stuff too?
We did, yeah. And I think the one thing that stood out to me is I remember reading this one paper. I'll have to send it to you, but basically they talked about the topography of how we perceive pain. And if you could like break it down into two factions, you have sort of cortical pain reception or cortical pain interpretation. And then you have subcortical pain interpretation. So in general, we process all our thoughts and emotions and motor activity and feelings. We process it all on the surface of the brain or the cortex. And then deep inside the brain on like the inner surfaces of the brain, especially on the insides of the temporal lobes. So if you think of your brain as like a fist like this, you have like your frontal lobe here, whereas this is where you control like motor movement, strength, abstract thought, planning, language, speaking, things like that. The back of the brain is more sensory and like visual spatial interpretation. And then the very back of the brain is like visual. Now you have this thumb here called the temporal lobe, and the temporal lobe is our like dictionary. This is where we process sound, language, and communication. On the inside of that, if you like peel that thumb back, this is called the mesial temporal lobe, and in there is where we have our most primitive brain functions. This is like anger, rage. This is where we like generate new memories, and this is where we learn. The hippocampus is in there, which is like a very important structure. And so we process pain sort of in two different areas. We process pain out here, and this gives you the where and what. It's like, I have pain right here, and it feels like burning. So it's like a very objective interpretation of pain. But then we also interpret pain on the inside there, where we process our emotions. And this is like the, why is this pain happening, and what do I do about it?
There's some fear associated with it.
Exactly. And so,
or memories of previous incidences that are similar.
All of it. So it's basically taking that stimulus that you're experiencing, and it's comparing it to prior experiences you've had, and then trying to figure out what is the best plan going forward to sort of handle this. And chronic pain arises when there is no sort of definitive plan about like how to make this pain go away.
Yeah.
And so your brain starts to dwell on it. So much so that the little areas on that inside part of the brain that are responsible for sort of processing and perceiving this emotional component to pain, they actually hypertrophy, they grow. We can see this on a functional MRI. So you put somebody in, a normal person, I hate saying normal person, but you put somebody without reports of chronic pain in an MRI,
yeah,
and you do certain painful stimuli, and you can see where those parts of the brain light up. And then you put someone who has chronic pain, or let's say fibromyalgia or something like that, and you do the same stimulus. Well, first of all, their pain stimulus threshold is much, much lower. So doing something to them that's not painful, they're actually perceiving pain. And we can see that because the pain center is lighting up in their brain.
Yeah.
And that center is literally volumetrically bigger. So their brain has devoted more neurons and more nutrients and more resources to try and figure out, why am I hurting? And that doesn't happen just in the brain. That actually happens in the spinal cord as well. And that kind of explains why things like spinal cord stimulation can help with chronic nerve pain, because the spinal cord stimulator is sort of helping the spinal cord rewire or go back to its pre-chronic pain state.
Interesting.
But going back to that sort of illustration here, you have this where and what objective interpretation of pain, and then you have this like why and how interpretation of pain. And what you might see is that in individuals who have brain injury, traumatic brain injury to the cortex of the brain, there tends to be this vague ambiguity to their pain. They don't know why, or they don't know what kind of pain. You ask them, where does it hurt? It hurts all over. Like, what does it feel like? And they have a really hard time sort of describing to you what it is. And that's because those areas of their brains is damaged. It's not functioning as well as it could be. And so they're left with a relatively disproportionately high emotional component to their pain.
Interesting.
And then
So and imagine then if somebody's been in chronic pain for a long time and that emotional, the mesenchymal, what was it?
The hippocampus or the mesial temporal lobe. Yeah.
Mesial temporal lobe is hypertrophy. It's bigger. The emotional components then would be amplified.
Yeah.
Is that accurate?
So it's interesting.
Similar to like if like a traumatic brain injury patient with a cortical brain of like the objective what and where is gone, then all is left is the emotional. Yeah. That's a great comparative.
Yeah. It's really bizarre.
When it's awful hard with that, and some studies and mental health professionals said the same thing of like the emotional pain from getting a breakup or a loss is coming from the same region of the brain. Is that accurate?
Yeah, I mean, gosh, I'd have to go back to my neuroanatomy, but that like rage and sadness and suffering, these all come from that kind of
same thing,
mesial temporal cortex.
Yeah. So that's what we're saying. Like so emotional reactions to loss or breakups and relationships, whatever, it hurts, right? They don't know how it hurts, but it just hurts. That makes total sense. Like, I don't know where it hurts or what, but it hurts.
Hurts deep down.
Hurts in my heart, right? Like relationship trauma, like difficulty with a breakup, like a loss of a family member, if someone's close to you, whatever. That makes total sense. Yeah. Because can't define, like my arm doesn't hurt, but I'm aching right now. It doesn't make sense. Mm-hmm. But anyway, so imagine if somebody with just in general, the thought of like the biopsychosocial model of medicine, right? Of like the biology, the psychological component, and then the social structure component that contributes to health, longevity, and the pain experience. Mm-hmm. Man, this connects so many dots and makes so much sense. Pain is coming from the same region that physical pain, that emotional pain also comes from. Yeah. So we can't disconnect the interplay between those two. And physical pain still elicits some kind of an emotional response. Mm-hmm. And you can't disconnect the mind from the body. And like, oh my gosh, that makes so much sense. Yeah. Right?
And just to add to that, so what's sitting, in between those two mesial cortex. So imagine if I had a thumb here, what's sitting in between these two inside regions is your hypothalamus. And the hypothalamus is basically like it's the headquarters for your entire endocrine system. So that's where you get all the initial signals for like, growth hormones and testosterone and estrogen and all these things. So it also regulates your metabolism. And then it's also the seat of your sympathetic nervous system, the fight or flight nervous system. So because they are so close, there's inevitably interplay there. And that's why when you feel anger and rage, you vasoconstrict and your pupils dilate and you get your heart rate goes up and your blood pressure goes up and so there's definitely direct communication there.
That makes a lot of sense. So it's just interesting. You can't neglect the physical changes can manifest, especially long-term from emotional and mental stress, anxiety. Yeah. Like physical manifestations and symptoms happen from just stress and anxiety. Yeah. And the emotional component. Yeah. It's just interesting because like with, at least from the conversations in our fellowship program, we talk about with pain science, they always talk about, we bring up like, whatever, you can't separate the mind from the body. And if there is chronic pain present, things still hurt, even if there's perceived danger. Yeah. Real or perceived. It's like, my pain is an 8 out of 10. Well, I can't tell you. Just the same way as I can't say, how happy are you? Well, I'm a 6 out of 10 happy. Well, you look like you're a 3 out of 10 happy.
It's like, really? You act like a 3?
Yeah, you act like a 3. Wow, that sucks. Like you can't tell somebody like, well, I'm an 8 out of 10. Well, no, you're not. Well, how would you know that? You can't, right? Yeah. The people just, it's their real. It's real for them, no matter what. It's totally real. Perceived danger or real danger to your tissues. Mm-hmm. So like if someone's been in pain for 13 years with back pain from a car accident, it's like, well, tissues heal in 6 to 8 weeks and bones heal in 12 to 16 weeks, depending on how healthy they are. But how are they still in pain? Mm-hmm. Where if we're touching their back, like, how's this feel? Does this hurt? Does that not hurt? Mm-hmm. Like, and they're like jumping off the table. And it's like, well, that's not a painful stimulus, but it's painful for them. It's painful and it's still real for them. We're not discrediting that. Yeah. But it's like, that's not a painful thing. And according to the images and after surgery, structurally, everything's good. Right. Like we're good. Yeah. Structurally, the tissues are fine, but you're still in pain. How's that possible? It's like, it's not real danger. It's just perceived danger at this point. We're not going to tell patients that, of course, but like it's just perceived at this point. So what are those perceptions and the fear associated with that, and some of the memories with the hippocampus, right? Because that's short-term memory, right? Or long-term memory?
Working memory. It's working memory. Yeah.
There's memory involved there too. Yeah. So it's like the memory is involved, and the hypothalamus, whatever you're just describing, and the temporal mesenchymal.
Mesial temporal.
Mesial temporal lobe.
If you say it fast enough, everybody will just agree.
Like, no, I just said mesenchymal stem cell. That's what I was thinking of. Yeah. Mesial temporal lobe. Man, all the interplay, it makes total sense. You know, of like, we're going to get physical manifestations. The emotional pain that comes with it is coming from the same center as physical pain. We can't disconnect that. And it's been going on for a long time. So the memories are still there. And it still hurts, even though it's not actual danger of the tissue. Yeah. So it's like, so what do we do, right? Like, how do you treat that?
I mean, big part of it is that there are actual structural chemical changes happening to your nervous system in response to the chronic pain. So like you have all the like supporting cells, what we call like microglia, which is like the scaffold of your nervous system. They start to change in ways that promote this sort of perception and transmission of pain signaling. So
interesting.
Yeah, it's like you have to have a top-down and a bottom-up approach to treating pain, and that actually illustrates another point that I see a lot in clinic, and that is that your images, by images I mean like MRIs and X-rays, they rarely correlate with your pain or the symptoms that you're having in severity and in location.
Totally true.
So I see patients that walk in and their MRI looks like a bomb went off, and they're just like, hey, I walk 10 miles every day and no problems, and then I see the opposite.
That's awesome. That makes sense. I walk 10 miles a day.
Yeah, exactly.
9 holes of golf, I'm good.
Yeah. And then I see the absolute opposite. I see very, mild, moderate, pathology on an imaging, and their life is very disrupted by what's going on. And I'm seeing physical changes because they have boggy tissue textures. They have, they might be a little bit edematous over certain muscles, or they have like ropey changes in their muscles. And it's like, okay, there's obviously something happening. Something that I've been meaning to explore more, and I have a former attending when I was in neurology residency who's like really done a deep dive on this, is exploring the like cellular biology behind our fascia. Because we know now that a fascia is basically, it's just an extension of our nervous system. It's the interface between our nervous system and our musculoskeletal system, and it penetrates everything. It's like cotton candy that just is all over the place. And so I feel like even if structures look fine and your spine looks fine, your alignments look good, and your discs look good, to our caveman eyeballs, you're still in pain. That's probably because something's happening on a microscopic level that we can't appreciate.
Through the fascia.
And I think that holds the answer to fibromyalgia as well. And I think there is a very close interplay between the health of our fascia and, our neurochemistry profile, like, being, I don't want to say serotonin deficient, but having, depressive symptoms and being chronically fatigued and so on. So there's definitely an interface there that I haven't been able to tease out yet, but I need to read more.
I'm not smart enough for that. That's really interesting. I mean, because we definitely have seen a plethora of patients that have chronic recurrences of pain, reports of being in pain for a long time, where imaging looks unremarkable. Where it's like, okay, some mild, maybe some moderate pathology evident on these images or the reports we're getting from the radiologists. You know what I mean? But there's definitely a disconnect of like the symptoms and the prognosis and the functionality to what the image and structure is showing, where it's like, let's not hang our hat on just what we're finding. It also doesn't dictate if we're going to get better or not, It's just a bummer because we see a lot of patients that come in and are like, my doctor told me that I have the back of an 80-year-old and it's bad. And we're not ready to do surgery yet. Yeah. Just not yet, but we need to, and you're effed. Until that. Yeah. So here's some Advil. And I'm like, so you went in the doctor's with like moderate back, maybe mild to moderate, 4 out of 10 pain. You left the doctor's office and that night your pain was at 8 out of 10. Nothing changed. Yeah. Except the image and the conversation. I'm like, man, that was a detriment, you know, like we need to rule some things out. I don't hate imaging by any means, but I'm like, there could be said differently. You know what I mean?
Yeah. And I wonder how much of it is also like expectation management too.
Oh, totally.
Yeah.
Yeah, totally. For sure.
You mentioned Advil.
Yeah. Okay. Yes.
You're going to make me wince.
Let's talk about that, because that's one of my main things. We talked about it last time.
Yeah.
I still want to ask about ibuprofen, not to bash the company, you know, like,
Yeah, right.
I don't want to get sued.
Well, it's generic now. You're good.
Yeah. Okay.
Nobody
Perfect.
holds the patent.
Good. Well, that's good. And then the functional spinal unit.
Yeah.
But anyway, all right. So ibuprofen, Advil.
Yeah. So ibuprofen is like the flagship non-steroidal anti-inflammatory drugs, or NSAIDs.
Yeah.
And that encompasses, ibuprofen, naproxen, Celebrex or celecoxib, meloxicam, ketorolac.
Meloxicam is an NSAID?
Mm-hmm.
Okay.
Ketorolac, diclofenac, etodolac. It goes on and on and on and on. There's so many of them. And they are just, they're everywhere. Some are over the counter, like ibuprofen and naproxen. And then a lot are prescription based.
So naproxen sodium is a leave.
Yeah, naproxen is a leave. Ibuprofen is Advil. Motrin, I think, is like a blend of ibuprofen and aspirin and I think caffeine.
And then Tylenol, acetaminophen.
Tylenol is acetaminophen. That is not an NSAID. That is an antipyretic, which means it works on your hypothalamus to regulate like your core body temperature and regulate inflammation. But it doesn't work on some of the enzymes that NSAIDs do.
Okay.
Yeah.
So, but Tylenol, it blocks pain receptors then, or signaling too? Or is it only temperature and...
It reduces inflammation by controlling your temperature.
That's it.
Interestingly enough. Yeah.
Okay.
Yeah. So that's why in my practice, I recommend using Tylenol for post-procedural pain. Because it doesn't cause platelet dysfunction. It's not an antiplatelet. It doesn't act on, your cyclooxygenase or lipooxygenase enzymes, which kind of modulate this inflammatory response and produce different types of tissue precursor cells. So Tylenol doesn't affect any of that. So I recommend Tylenol for acute pain. Okay. But I don't recommend Tylenol for everyday pain management, because inevitably you will get, oh my God, the word is escaping me right now. Tachyphylaxis, which is a fancy word for just getting used to it. Okay. So eventually your body sort of gets accustomed to having this outside source of this kind of...
So it starts acting like decaf.
Yeah, you become a little bit dependent on it. Yeah. So you'll start to get like rebound headaches and rebound aching and stuff like that.
Interesting.
So I always limit those kinds of medications to no more than 2 to 3 times in a week.
Oh, wow.
Yeah.
When does what was the word?
Tachyphylaxis.
Tachyphylaxis.
Yeah, it can happen as quickly as 3 days.
Huh.
Yeah. If you're using it every day for 3 days, you can develop a tolerance very quickly. And so a lot of the times, because of my neurology background, I see a lot of headaches. And I would say 70% of patients I see with headache have a medication overuse component.
Huh.
Whether they know about it or not is different, but most of the time they don't know.
What's the common ones? Tylenol, Advil?
Yeah, Tylenol, Advil, Aleve, aspirin, like goodies and BC powder, all those things. And then in some cases, like the migraine rescue meds, like the triptans and the ergots and things like that.
Okay.
Yeah.
Where does coffee fall on that?
I love coffee.
I'm a coffee guy.
Yeah.
I'm not a coffee snob. I'm cool with Dunkin' Donuts, dude. I'm like, yo, give me one pump. Otherwise it's overwhelming. Yeah. I'm like, oh, it just tastes gross.
I know. To be honest, I've purposefully not really looked too much into coffee because I don't want to spoil it for me. But what I do, I know.
I'm just gonna leave that unturned. I'm not gonna open that up.
What I do know is that the rebound headache you get from coffee is because caffeine helps us vasoconstrict. It basically increases our sympathetic drive and tells our
stimulant.
Yeah, it's a stimulant. Yeah, so it tells our arteries to sort of tighten down, and that's why it wakes us up and we feel really great. If you're dependent on caffeine and you go a morning without your caffeine, well, those arteries are sitting there waiting for this signal to be like, hey, tighten up, it's time to go to work. Yeah. Well, that's usually not an issue. Where it becomes an issue is where the arteries penetrate the blood-brain barrier or the meninges. So at the tiny little holes in the skull, particularly in the back of the skull, you have all these little holes called foramen, and your blood vessels go in and out of these. Well, at that entrance of those little holes is your meninges, the wrapping of your brain. And those are loaded with pain receptors. And so if you have an artery going through there and that artery relies on coffee to sort of constrict and there's no coffee there, what happens is that artery is like kind of swollen and dilated and then it's pulsing. So it's pumping against the meninges. It's like hitting the meninges.
Yeah. Where is my coffee?
Yeah, where's my coffee? And you're getting that like just back of the head headache. Okay. Sometimes you get it here. So
we'll have to have a whole podcast on headaches. That's super interesting.
Yeah.
Yeah, that's all because not definitely not a strong suit of mine by any means. Well, that's really cool. All right, so that's Tylenol, and you recommend that for post procedural short term relief.
Yeah,
exactly. I was going to ask you that. Let's say there's an athlete who's like, you had a competition. We're playing today.
Yeah,
I got hurt. Mm-hmm. I need something to feel better.
Yeah.
I was told by a trainer back in my day, I like sprained my ankle pretty bad, and we were playing like a major school, and I wanted to try it was a big time thing, and I was like, I'm playing.
Yeah,
like my ankle was jacked. It was black. It was huge. You know, I couldn't walk on it for 2 days after I sprained it.
Or something.
Maybe.
Yeah.
Wrapped it up, tried to get the swelling out, and then I was like, I'm practicing tomorrow. I'm not practicing because I got to practice this week in order to travel for later this week.
Yeah.
And the trainer was like, just wrap it, take 4 Advil at breakfast, 4 at lunch, and 4 at dinner for the next 3 days. So 12 a day for the next 3 days. I know.
Dang.
I was like, yes, sir.
Yeah.
I'm getting
What are you going to say? No.
Yeah. I'm like, I want to play.
Yeah.
So I wrapped it up. I practiced that day. It hurt. You know,
Yeah.
The next day it didn't feel great. Loaded up on Advil. Didn't feel good. But anyway, yeah. So what do you do? What do you recommend? Tylenol then?
Yeah. So if it's like an acute injury, like a sprained ankle and there's swelling and heat and bruising, then it's probably appropriate to take an NSAID, especially if like you have to do something the next day, like what you just described.
Sports or something.
Yeah.
Would Tylenol be your go-to, or would you suggest?
Well, it really depends on like the the foundation of sort of pain relief that you have, right? So if you are someone who is like, in a pro-inflammatory state, just kind of like the average pro-inflammatory state, then reaching for what I would otherwise recommend, which is like Tylenol, curcumin, and heat, like, topical heat or like a heat pad or like a CBD cream.
Okay.
That's what I would recommend. But if you are not, how do I rephrase this? It's like, it might not be strong enough and you might need an NSAID in that case, which I'll also talk about the timing of NSAIDs because that's important as well. In general, what I recommend for acute pain is Tylenol. Your max daily allowable dose of Tylenol is 3 grams, 3,000 milligrams. So if you're going to take Tylenol, take enough so that it actually makes a difference. So take 1,000 milligrams and then take it again in 6 hours if you need to, but don't exceed 3,000 milligrams.
For the day or for each dose?
For the 3,000 milligrams is the daily dose. Yeah, 24 hours.
Okay.
Yeah. But if you're going to take it, take a whopping dose up front just so you can actually make that difference. Curcumin, which is a derivative of turmeric, which is an extract of curcumin, with black pepper extract is, a good option as well. That's more of like a long-term kind of solution. So, because it acts on a different mechanism. It's more of like a genomic transcription thing where it reduces your expression of inflammatory markers in general over time.
Huh.
So it doesn't act like a quick acting like we would expect Tylenol or Advil to, but it is a good baseline to build on. Also, omega-3 fatty acids.
Okay.
Omega-3 specifically. When you buy a supplement, you got to look at the label and see how many milligrams of omega-3 is there compared to like 6 and 9 and other things. So 3,000 milligrams of omega-3 fatty acids acts in a similar fashion as an anti-inflammatory without the platelet dysfunction.
Okay.
So Tylenol, omega-3, curcumin, and then CBD ointments.
Okay.
And not to shamelessly name drop or anything, but there's a CBD that I use and recommend called CBMD. And they're basically high potency, third party verified,
cool.
all the above. And it's got like menthol and camphor in it as well. So it like gives you that cooling kind of distraction effect as well.
Interesting.
Yeah.
And it's a cream.
That's
What are the oil? CBD oil,
Yeah, you can do
like under the tongue.
tinctures. Yeah, I personally think tinctures are great for more like low-grade chronic pain and like anxiety.
Okay.
It has mood stabilizing effects. It also kind of helps gut health. So if you want more of like a general health approach, then yeah, the tincture is probably better.
Cool. That's really cool. All right. Man, I've been taking turmeric with black pepper, and I'm open to ideas for brands and stuff, but just from Costco, because it's the biggest. Cunol is the brand.
Yeah, Cunol. Yeah.
Is that solid?
I think so.
How much? Yeah. And then stacking that with fish oil, Nordic Natural. From what I was told, and confirm or tell me your thoughts, the EPA and DHA molecules is the most. This is the thing you want to look for the most density of its effectiveness.
Yeah,
is that correct? Or omega, just to make sure it's omega-3 and not 9 or 6, like you were saying.
Yeah, I mean, from what I know is that you want to find the omega-3, but I should probably look into that a little bit more.
Okay, and then but taking all those simultaneously, what dose of turmeric?
I think it's what I have is 300 milligram. Yeah, it's a 300 milligram dose of curcumin. Yeah.
And then what about ginger? Have you heard any anti-inflammatory properties with that?
Anecdotally, I haven't honestly looked into it too much.
Okay.
I do know that there's something called resveratrol. Resveratrol is an extract from the skin of the grape that is very good at maintaining what's called like endothelial health. So on the inside of the arteries, it has this thin 1 cell thick lining called endothelium. And that's basically like where all your first responders are to any sort of vascular injury. And so resveratrol helps kind of like stabilize that membrane so that it's not so reactive and oxidative.
So I would imagine that would help with thrombolytic type of development or atherosclerosis, stroke. Mm-hmm. Interesting.
Yeah.
What's it called?
Resveratrol.
Cool. All right, that's cool. That's very interesting.
Yeah, and then I think I've read that vitamin D also has some anti-inflammatory effects as well.
Interesting. I've heard a lot of things about turmeric and black pepper.
Yeah.
The Cunol I've been taking recently, I'm researching about ginger, apparently some similar effects. It was like turmeric, black pepper, and ginger, and then taking omega-3. And then coffee.
And coffee.
But I like the CBD. That's a good idea. So
that's one thing that like I'll admit is an area that I wish I could dedicate like a lot more time in reading is getting stronger with my supplements.
Yeah.
And like supplementing diet, because I feel like there's just so much room for improvement in that arena.
Yeah.
And you can get lost in the literature.
Yeah, totally. All right. So explain Advil. Why is it no bueno?
Yeah. So basically the non-steroidal anti-inflammatories, they act in like a bottom up fashion. So they basically take, your platelets, which modulate the inflammatory reaction to sort of injury, and they cause platelet dysfunction. They inhibit molecules like cyclooxygenase and lipoxygenase. And essentially what's happening is by taking these medications, you're stopping inflammation by stopping the cells that start the healing cascade, right? If you have to take them, it's better to take them in the morning than at night, because throughout, our kind of diurnal course of the day, from the moment we wake up to the moment we go to sleep, we sort of accumulate micro injuries just from being around and existing. And that's fine. But at night, when we're getting good sleep, that's when and this is why REM sleep is so important, and just having a good sleep hygiene is so important, because that is the opportunity for our body to sort of assess what has gone on that day and then damage control and then heal and repair, basically. So it has to happen at night. That's why when you pull an all-nighter, you have a sleepless night, or you're not getting good sleep, or you have sleep apnea, that's why your chronic pain gets worse, is because you're never really getting that opportunity to enter that healing, repairing, lymphatic phase of sleep.
Yeah. And then stress and anxiety increase because you're not sleeping good and you're hurting more. Yeah. And then you're not sleeping good because of that. And then you have more anxiety because you're not sleeping. And
exactly. And then you have more stress, and then the stress affects your memory and concentration. And so if you taking NSAIDs at night, you're essentially just stopping that healing and repairing process that your body naturally goes through. at night. And so there was a study where it was like a mouse study where they induced tibial fractures in the mice. And then they had some mice take NSAIDs at the beginning of the day, and then like an actual pain medication like oxycodone or something like that at night, and then vice versa for the other mice. And I can't remember what time period, but basically they sacrificed the mice, and then they looked at how the bones were healing. And essentially the mice that were taking it at night, they just had way worse, non-union, and they were worse off essentially. So we know that taking NSAIDs at night is probably not a good idea.
Interesting. Yeah. Okay.
Yeah. So if you have to take it,
yeah,
take it with food in the morning.
Yeah. But you're not a fan of it just because it blocks from the ground up the natural inflammatory responses that we want to have happen that would facilitate healing.
Yeah.
Otherwise.
And it stops, it stops things like cartilage growth. It inhibits blood flow to, very, very small capillary beds. So things that are vulnerable to that are like your vertebral discs. Your vertebral discs don't really get their own blood supply to begin with. So they kind of require this sort of diffusion of blood across like the end plates from the bones. The vertebral bone. And so that kind of stops that blood flow. So they're not getting nutrients. So now they're more susceptible to being degenerated. Naproxen, for example, is the worst for cartilage because it inhibits this molecule called lipooxygenase, which is responsible for making like the fatty chemicals that sort of are a part of a building block for cartilage. What else? I mean, the list goes on. The other big one is that similar to what we were talking about with Tylenol earlier, is there's that tachyphylaxis effect. So you become quickly dependent on it. The way I see it progress is like someone has an injury and then they take the NSAIDs in order to sort of get over that pain and be able to function for like the next day or something like that. But then it quickly transitions from that to now they need it in order to get over any sort of pain. And then it transitions to now I need it every day to just kind of not have pain in general. And so then they become quickly dependent on it. And then the degenerative issues start to sort of speed up at that point.
Yeah.
Yeah.
And if that's becoming decaf for them, next step.
What do you mean decaf?
Like decaf, like it's not cap, like at this
point.
It's like, it's not effective,
Yeah.
Then that would assume that they would try to pursue prescription-based pain meds.
Yeah. It ends up happening if the over-the-counter ones aren't effective, then, they go to their doctor and the doctor goes, okay, well, here's meloxicam or here's celecoxib,
So what meloxicam, from what I heard, it's a muscle relaxer. Is that correct or not?
No, that's, oh my gosh. Wow, the word's escaping me. No, meloxicam is an anti-inflammatory, and then I can't remember. I don't know why I can't remember the muscle relaxer. It'll come to me.
Well,
there's like 4 common ones. Yeah,
but I'm drawing a blank too because I've seen all the time on scripts.
I haven't prescribed it in so long.
Well, there you go.
Forgetting.
Well, good.
Yeah.
But like meloxicam's an NSAID. It's just a prescription med NSAID.
Yeah, it's a prescription NSAID, and its whole thing was either meloxicam or celecoxib. One of them had a theoretically less increased risk for heart attack and stroke, and then the other one theoretically had a less risk for stomach ulcers and things like that. So what ends up happening is like you get this medication that some trial showed like, oh, it's a little bit decreased risk of this. And then insurance companies will approve that for any person that has knee pain and has a history of peptic ulcer disease. So they're getting that med.
Yeah.
Or anyone that has back pain and has a history of coronary artery disease, they're getting that other one. And so how valid is that data? I don't know. Yeah. There's kind of an agenda behind it.
I don't disagree
but
with
I'll stop there. Otherwise I'll disappear at some point.
Yeah, as I said, like we got to get that guy. No more podcasts for this
I'm not
guy.
paranoid.
Yeah, exactly. We'll have to talk. No, I'm on the same boat, man. I think like, insurance, it makes sense. It's a cool concept. It's just naturally human greed, I feel like, which is always the problem. It seems like with everything, is just becoming so convoluted and difficult that like health insurance runs the world pretty much.
Yeah.
From my understanding, where big pharma is still the little brother.
Mm.
Did you ever see that? There's a Netflix documentary on this. I don't know, just chronicling that. And it's just super interesting. And there's this really cool Joe Rogan podcast that they dive into this.
Really?
Yeah. And the guy, he used to work he was an insurance sales rep, and also pharmacology or pharmaceutical sales rep. And he was like, we were still beholden to the insurance company. Like Big Pharma is still the little brother to insurance. They dictate the world right now, especially in the healthcare at least. Yeah. But anyway, and the thing about the companies that invest and own those health insurance companies, I'm just saying, I don't know, man. You know, like something's going on here.
You know, it's kind of like, you know, since I stepped away from that, it's like ignorance is, I guess, is kind of bliss, but I should probably stay in tune.
Stay in tune, yeah. All right, interesting. And then our last thing, well, for today, you mentioned the functional spinal unit, right? For just the lens and how you all perceive how the cervical spine, thoracic spine, and lumbar spine work together. Explain more of that.
Yeah, so the functional spinal unit is kind of how we break down the spine. And so the spine, as you know, is like this Jenga tower of vertebra. And you have these three main domains. You have the cervical, thoracic, and lumbar. You know, they're all kind of shaped a certain way because they're tasked with a certain function. And so the functional spinal unit is comprised of the interface between two adjacent segments. So the bottom half of one vertebrae and the top half of the vertebrae below it and everything in between. And so that is basically, we'll take lumbar spine, for example. So like the bottom half of L1 and the top half of L2. So that is the interface between that and the disc. So the intervertebral disc there is sort of the midline. Then you have the facet joints, which is I should have brought my spine model. The facet joints, which is like the joints in the back of the spine. Yeah.
I'm such a nerd.
I'm doing all this stuff with my hands. Yeah. So yeah, you have like the vertebral bodies, their interface with the disc. Then you have, you know, the joints that are formed when you stack two vertebrae on top of each other, and those are the facet joints. Then you have, you know, the spinal canal and the neuroforamen, which is where the spinal cord and the spinal nerves sort of go through or exist. And then all the ligaments that hold them together. So around the vertebral bodies, you have the anterior longitudinal ligament, and then behind that, the PLL, posterior longitudinal, and then you have spinal cord, and then behind that, you have the ligamentum flavum, which is like this big, thick yellow ligament, basically. And then interspinous, supraspinous, intertrans. So there's just a whole network of ligaments that sort of hold these two vertebrae together. And then you have all the muscles that are what I call one-to-one deep stabilizers or deep segmental stabilizers. These are muscles that start from one vertebrae and go to the immediately adjacent vertebrae, as opposed to long segment stabilizers, which go from one to like 3, 4, maybe even more, you know, vertebrae down the road. Yeah. So all those structures make up the functional spinal unit. And when we approach a degenerated spine or a painful spine, we have to examine all those structures in the functional spinal unit and figure out, you know, we have to get away from the pain generator model. The current sort of pain management model is like, find the one thing that hurts the most and stop that. So when you do that, you inevitably end up chasing your tail, because you're going to stop one thing and then another thing becomes now the main problem, and then the next thing becomes the main problem. But if you look at the functional spinal unit, then you can figure out where did that dysfunction arise and how. And then if you can treat those things, all of those, you know, functional units inside that model, then you can promote stability in that spine. So the thing I see most commonly in the lumbar spine, at least we'll use that as a common example, is you have these two units. You start to have degeneration of the disc. Now, disc degeneration is like wrinkles. We all have it. I think 30% of the population above the age of 20 has some degree of disc degeneration. And so when a disc degenerates, I think I stole that from your podcast like a couple of weeks ago, actually.
Yeah. On the imaging.
Yeah.
It was like, it's insane.
Yeah.
But like 45% of people over the age of 43 have some kind of...
It's crazy.
Like 73% of people at 43 years old, 45 years old.
Yeah.
It's a lot.
So I love it when somebody comes in, they're like, it's my slip disc. I'm like, join the, you know,
it's the old L5 S1. It's like, okay, everybody has that.
So, you know, you start out with this like nice, plump, healthy disc. And the height of that disc matters, because if you have a plump disc, then the ligaments that are holding those things together are taut. They're under the appropriate amount of tension that they need to be under. If that disc starts to degenerate, which we can talk about what causes this to degenerate later. But essentially, that disc gets like little micro fissures in its wrapping, and it starts to leak the contents of its disc. And gradually over time, even without herniations or protrusions or extrusions, whatever, over time, that disc starts to lose its height. It just kind of slowly shrinks. And I can see that on an MRI because a degenerated disc goes from this nice, shiny, white-looking plump disc, and it starts to turn gray and then black, and then you see it sort of shrink. When you lose that height, those ligaments that are stabilizing that unit in the front, back, and the sides become a little bit lax, right? And so now you have this just micro instability, a little bit of wobble between those units. You also have now increased pressure and load on those facet joints that were in the back. Those facet joints are not really supposed to bear any weight. They're supposed to, dictate movement. And so you get this kind of wiggly wobbly unit, right? Well, your brain senses this because it has a lot of position sense fibers in there. And it says, hey, there's something wrong. This is moving not the way it should be. We need to stabilize this. So it sends an order to the muscles to say, work overtime. So those muscles clamp down.
Muscle guarding, spasms.
Muscle guarding spasm. Yeah, that acute spasm is exactly that. That like, oh, I was in bed for a week. That's a muscle spasm because something has become unstable suddenly.
Like enough danger was perceived for everything else to take action. Like, oh, hang on.
Yeah,
don't
exactly.
Do that.
And those muscles clamp down. And then if they don't really get a good blood supply or they're kind of weaker than they should be, then they don't get the blood and the signals that they need to relax. And so that muscle is stuck in that contracted position, almost like rigor mortis. And that is painful.
Yeah, sucks.
Yeah. All right. So you get that little bit of instability there. Brain senses it, contracts those muscles down. Now those muscles are working overtime without getting paid overtime. And they start to inhibit. They start to shut off or atrophy because now they're not getting the appropriate nutrients, those deep segmental stabilizing muscles, aka the multifidus muscles, they start to suffer first, and then they start to recruit the help of their neighbors, the long segment stabilizer muscles. And so now those things are not only are they doing intricate long distance work, but now they also have to work overtime and stabilize, their immediate segments. So now they're getting overworked. And they attach to other things like your rib angles. They attach up a little bit higher. So now down the road, you start to get like trigger points and pain along the margins of your ribs. Going back to the spinal unit itself, that little bit of instability and that increased movement starts to wear down the ligaments. And then the ligaments try to repair themselves, but they repair themselves in a disorganized fashion. So they start to get a little bit thicker. The ligaments that are inside that spinal canal, when you lose that height, they start to buckle, and they buckle in towards the spinal cord, and they buckle in towards the spinal nerves.
So it narrows the space for
exactly.
The cauda equina and the spinal cord.
Exactly.
Yeah, so it's a cascade of a lot of stuff.
Yeah. And so you have to really look at all those factors. So when we treat the functional spinal unit with biologics, I know that like the baseline things that you have to treat are the ligaments and the muscles and the facet joints that are implicated in that degenerated level. No matter what you do, you have to treat those. Then outside of that, you sort of decide which structures are symptomatic and which structures are, like if somebody has some degenerative scoliosis, I know that at the apex of that, that curve, there's going to be facet irritation, facet joint swelling. So we're going to treat that facet joint. I know that there's probably going to be some narrowing around that nerve root. So we're going to do platelet lysate injections there to wash out some of those inflammatory markers and give the nerve some nutrients.
Yeah.
And then in some cases, if the disc is, not completely degenerated, or if it's got an annular tear, or if it's bulging a little bit, then you can actually put platelets into the disc itself to help sort of seal up whatever that annular fissure was so that it stops losing its goodies. The other thing to keep in mind is when you have a degenerated disc, it's leaking out its contents. And those contents are primarily what's called glycosaminoglycans. It's like these sugary molecules, very caustic to the nerves. And so without even touching a nerve or having a bulging disc that's compressing a nerve, you have this inflammatory milieu that's just irritating the spinal nerve root. And so the patient would start to feel increased nerve symptoms. They would have sensitivity, they would have tingling, they'd have pain. The muscles would be twitching and fasciculating because that nerve is like firing off when it shouldn't be.
Yeah.
Right. As opposed to structural compression of a nerve, you know, the lifeline of an irritated nerve, or like the lifespan of an irritated nerve, is healthy nerve starts to get irritated because of those caustic chemicals, and you have increased nerve symptoms. Now, let's say that disc continues to degenerate and it bulges and it starts to touch the nerve now. Well, initially you're going to get that classic lightning bolt sciatic pain because something is touching those sensory fibers on the outside of the nerve. As it continues to compress that, those sensory fibers on the outside of the nerve die off. So the pain goes away. That's, you might think, oh, I'm getting better.
Good. Yeah.
Compression continues, and now that pressure is starting to affect the motor fibers on the inside of that nerve.
You drop foot.
Yeah. And so then you start to get weakness. And then if that continues, then you get atrophy and so on. So it's like increased nerve symptoms and then now decreased nerve symptoms.
And refer. Yeah.
Yeah.
Interesting. Man, that's crazy. I could see and imagine where it's like, let's help from a pathoanatomical standpoint, which is orthopedic surgeons, which they deserve a ton of respect, and the insane, rigorous academic directions. Like, it's insane.
Yeah.
And they're super smart, but I could see from their end, right? Their lens is super pathoanatomical of like, okay, here's a wobbly spinal unit. Let's just fuse that thing.
Yeah.
Problem solved.
Yeah.
Or there's narrowing of the foramina where the nerve root passes through, or the disc contents is compressing against the nerve and encroaching on there. Let's just debride that out, clean it up, create more freedom of movement for the nerve, and then get the disc contents that are contributing to issues, get that out of there too. Clean it up, make it look structurally more sound.
Yeah. Yeah.
Which can have good effects and then also cannot. And and at least for what I've been exposed to, the outcomes after surgery for discectomy and foraminotomy, laminectomy, debridement, whatever, all that stuff, but definitely not a fusion. It's not enough consistent outcomes in the positive for me to be like, oh yeah, problem solved. Like, dude, just get a discectomy. Like, just do that. Totally. Yeah. I don't think I would go that route. Yeah. It's like, but what are your thoughts on that? I used to think, like, I used to just put this kind of like ban on all. I was like, surgery is bad. You don't need surgery. Well, I've learned that that's not the case. I think what surgery does really, really well, especially nowadays with a lot of advancements and how they do the surgery. So, we have a little bit of a selection bias because we see patients that have chronic pain from surgeries they may have gotten years and years ago. And the surgery technology was different back then. And now, what they're doing, using augmented reality to directly place these pedicle screws and things like that, it's come a long way. And then they can do this and minimally disrupt fascia. So I'm very hopeful in that regard. Yeah, so that's cool. Where surgery is great is that it's great for sort of restoring that proper structure, right? Especially in the cervical spine, where all the problems in the cervical spine arise from that loss of curve. Doing cervical fusion restores that curve, and there are definitely good outcomes from that because you're kind of preserving nerve and spinal root. Right. Where I personally think surgery falls short is that it's probably not addressing all the components of this person's pain, and not because they don't want to or oversight, but it's just like surgery is there to do one thing. It's restore function, preserve nerves, and preserve, that sort of mechanism, but it's not going to address fascial dysfunction. It's not going to address like muscle atrophy. If anything, it could potentially make muscle atrophy worse. And then you still have the adjacent segment disease problem that sort of shows up down the road. Yeah. And I'm lumping surgery into fusion. I'm talking about fusion primarily. So when I think fusion is indicated, how are we on time? Oh, you're good. Okay. So when I think fusion is indicated, it's definitely indicated. Meaning, like, if there's severe nerve root compression, if there's spinal cord compression, if there's so much instability that you're getting like bone fractures, and then I think they need hardware there. But of course, what I don't agree with is if there's like a bulging disc, just going and snipping disc out. It's like, well, now you are left with less disc volume, and you have this snipping site, or like that, the site where they excise disc, that is probably prone to
injury. Or if you go in and do like a foraminotomy, yeah, okay, you cleaned up that joint, but we didn't address the instability that led to an arthritic joint in the first place. Or my favorite, these like minimally invasive spine things that has kind of taken pain management by storm, which is where they just, oh, there's one problem here, let's shove a device in it and see if we can open up that problem. And they just completely disregard the overall spinal mechanics. There's something called an interspinous fusion device that it's basically like a car jack that you wedge in between the spinous processes. So if you have two, vertebrae that are degenerated and kind of compressed and buckled down on itself, you have, swollen facet joints and buckled ligaments and all that. And it's causing stenosis around the nerves and spinal cord. Well, this magic solution is you take this little jack and you completely obliterate the posterior ligaments, wedge this thing in between the spinous processes, and then you just prop it open like that. So now, not only are you putting a tremendous amount of tensile force on those spinous processes that may fracture at some point, but you've also destroyed the posterior ligaments that maintain this crucial stability of the spine, and you're inducing kyphosis. You're getting rid of that natural curve. Yeah. So it's just like, these people are going to have problems down the road,
I've never heard that. That's interesting.
Yeah. I mean, yeah, it's kind of crazy. So there's definitely, I think the most useful type of surgery there are the fusion type surgeries that are coming out now.
For cervical spine?
For cervical spine, even now for some lumbar spine things. But
okay.
Again, it's like when it's done well and it's done for the right indication, they have great outcomes. But the problem is that like, it ends up being the only option for a lot of people because they haven't been able to explore other options. They haven't found good therapy. They've exhausted corticosteroids, or they don't know about orthobiologics, or they can't afford it, something like that. And so they end up getting surgery because it's the only other option, and they may not have good outcomes.
Yeah, well, I mean, I definitely want to clear, like, I don't hate surgery by any means. I think there's a time for it. I want people to understand, like, I'm not anti-surgery. There's definitely, it could be life-saving. It could be great outcomes for people. And I'd have to admit too, like, I need to be mindful and conscious that we usually see people where they're still in pain and it hasn't been great for them. Mm-hmm. But we don't see the people that are running around and feel great.
Right.
That had surgery, and we don't even know that because we haven't seen them because they're not having pain. You know what I mean? So I can appreciate that.
I think it comes down to not really even the surgeon, but it comes down to the diagnosis. It's like, did they get the diagnosis correct? If the person is in there with back pain because they have, myofascial pain and, iliolumbar ligament strain and all this stuff, and then you do a fusion, like, they're not going to have good outcomes, right? But if they're having pain because they're having nerve root compression, okay, yeah, great. Fusion's going to help.
Be an option. Yeah.
Yeah.
Yeah, that makes total sense.
Yeah.
Awesome, man. Well, I got 2 more ideas of podcast episodes.
Nice.
With headaches.
Okay. Yeah.
And then just degenerative discs in general. Yeah. More just diving into that.
I'll bring some models.
Yeah, totally. I have a spine model in my office. I should have brought it with me too. It's like, I should have brought my disc model. It's like pulling out like Ron Burgundy. Like, I'm totally unprepared. Here's a disc model. Actually, let's talk about this. It's like, we're at dinner. Everybody relax.
Yeah.
That's awesome. Oh, yeah, man. Well, dude, thank you. I appreciate it. That's really cool information and insightful stuff, especially about NSAIDs and all that stuff. That's cool. But if anybody wants to reach out to you, what's the best way they can hit you up?
Yeah. So you can go to my website, palmbeachregen.com. Our phone number's on there as well. Or you can find me on Instagram. It's docregen, DOCREGEN. I think that's the same for my YouTube as well. So yeah, you can reach out to me.
Cool. Perfect. Yeah, we copied you on that car accident.
I love it.
I hurt my back dude. That took 3 takes. Yeah. And my second one, I was like, that didn't feel good.
I know, right?
It's messed up.
And it was a funny angle because you had to go feet first. So you're kind of doing this like slide.
I did it backward. I don't know. I was just like, I'm just going to roll over this ball and then pretend, and it looked somewhat cool. I was like, hopefully it'll look as cool as Dr. Ghattas did. Awesome. Well, thanks for coming in, man. We'll definitely have round 3 and round 4 with other things we can talk about. Yeah. We could talk about this stuff all day. And if you have any questions, we're always open to suggestions, comments, questions, concerns, podcast ideas and stuff. And if you want to reach out to us to ask any questions, we're always open to chatting with patients and maybe the best next direction you guys can go. And Dr. Ghattas is definitely a great option for that. But if you have any questions, definitely reach out to us. Our email is probably the best way, team@athleterc.com, or our phone number 561-899-8725. We're looking forward to chat with you guys and helping everybody in the community. And we'll catch y'all next time.
Right on.